so we can get started. So just to introduce myself for anyone who doesn't know me, my name's Sarah Murch. Me and my colleague Rachel are in the membership team at University Hospitals Bristol and Western NHS Foundation Trust, and we organise these Health Matters events to tell people about different aspects of care in our hospitals and different services that we provide. And anyone can come to them. They're open to the members of the public, staff and Foundation Trust members and governors and anyone who wants to come to them. So just a few housekeeping rules to start with. Please don't record the event or take pictures of it. We're going to ask you not to do that. We are actually going to record the first half of the event, the presentations. We're going to turn the recording off during the Q&A session so that people feel a bit freer to ask questions that they want to ask. Please feel free to keep your videos on or turn them off if you prefer. It's entirely up to you. I like seeing lots of faces on the screen, so quite happy for you to keep them on if you want. But if you'd rather not, then do turn it off. If everyone would please mute their microphones now and check they're on mute unless you are presenting or asking a question. So we're going to have the presentations first and then the Q&A session. So what I suggest you do, if questions occur to you during the presentations, please do type them into the chat box, which you should be able to find, coming up on the side of your screen. And we can answer any questions in the chat box in the Q&A session, and also you'll be able to just stick your hand up in the Q&A session if you prefer to do that as well. And just finally a reminder that obviously we can't discuss individual cases, so if you have an individual question about your own care, then obviously we can't discuss it at the event, but we can provide contact details for you to speak to people outside the meeting. So just here is the programme for today. We're very pleased that we've got some really good speakers from our stroke team here at the Trust. So we've got Pauline Baker, Lauren Carris and Helen Ellis, and they're going to speak first, just taking you through the patient journey. What happens when you first have a stroke, when you get taken to A&E, what happens in the stroke unit and on the ward, and planning for discharge. And then we're going to hand over to Bristol After Stroke, Rebecca Sheehy from Bristol After Stroke, and Verity Aldous from the Stroke Association, who are going to talk a bit about support is provided outside the hospital for those returning when you return home. And then we will open it for questions and answers. So I am now going to hand over to Pauline to start the first presentation. Pauline.
Hello. Can you all hear me?
Yeah.
You can. Okay, good. So I'm Pauline. I'm one of the stroke specialist nurses at the BRI. If we can go on to the first slide, please. And I'm going to talk about what is a stroke. So it's basically a brain attack. It's caused when the blood supply to part of the brain is cut off. If I can have the next slide, please. There's two things that can happen. The most common thing that happens is that a clot can block an artery in the brain, or blood can leak from a blood vessel in or around the brain. This disrupts the blood supply to part of the brain and it causes the symptoms of stroke. Hemorrhage accounts for about 15% of all strokes, and ischemic stroke is the most common. And it may be that when you're in hospital you might hear terms like ischemic stroke, infarction, and basically what it means is that there's been damage to that area of the brain, and sometimes that damage isn't very recoverable. Can I have the next slide, please? So the symptoms occur suddenly. So acting fast, which we'll talk about next, will give the patient or the person who's having a stroke the best chance of survival and recovery. The other thing that can happen is that people do actually go to bed and feel perfectly fine, and then they wake up in the night or in the morning and they've got stroke symptoms, which is why we want the people to act fast and call 999. The symptoms on the FAST campaign, so facial weakness, arm weakness, speech problems such as do you have slurred speech, or can you not get the right words out, those are some of the common symptoms of stroke, but there are other things that can happen that can actually indicate you're having a stroke. Can I have the next slide, please? So people, apart from a facial weakness or a speech problem or an arm weakness, can have weakness in one side of the body that can affect the arm and leg as well as the face, but they can have numbness. They can have blurred vision or loss of sight in one or both eyes. They can have double vision sometimes. They can have balance and coordination problems. You can get sudden memory loss, confusion, dizziness or fall, or a sudden severe headache. And these symptoms are actually linked to which area of the brain is being affected by the stroke. Can I have the next slide, please? So when somebody comes into the BRI, we hope that you've all called 999 and you've been picked up by an ambulance crew. The paramedic crew will assess you, and if your symptoms have occurred within 24 hours or you've got a definite time of onset, they will actually phone the emergency department at the BRI and say that we have a fast positive patient, which means you have stroke signs. The BRI emergency department will request a brain scan called CT, and the paramedics will take you straight to CT scan so that we can image your brain as quickly as possible. They will also put out a call to the medical team for thrombolysis, and they will come down, if can I have the next slide please, to assess you. So you'll have your CT scan, you will then get taken back to the emergency department where the assessment by the doctors will continue. They want to know, when did your symptoms start? Have we got any witnesses? They want to know a little bit about your medical history, any recent illnesses, injuries or surgery. The nursing staff will look at measuring your blood pressure, your heart rate, your temperature, your respiratory rate and your oxygen levels. They'll also do bloods and an ECG, which is a heart tracing, and later on we will look at your swallow and just check whether you've got any issues there. Can I have the next slide? So the two emergency treatments that are that we can look at assessing people for that have come in with stroke within 24 hours are either thrombolysis, which is when we give a medication called alteplase, which aims to dissolve the clot in the brain that's causing the stroke symptoms. We can only give this medication within 4.5 hours of onset, so it's very important that we know what time your symptoms happened. If somebody goes to bed and is fine but wakes up with a stroke, we can't actually thrombolyse because we don't know when your stroke occurred in the night, so you wouldn't be suitable for this treatment. But there is another treatment we'll talk about later. So there are contraindications to this medication, so not everybody can have it, but for every 3 people that are treated, 1 person will achieve a better recovery, and every 9 people that are treated, 1 person achieves a full recovery. Thrombolysis will actually improve people more than it will cause issues. So the other option that we can look at providing people with stroke to treat them with is called clot retrieval or thrombectomy. And this is something that we can assess and we can start the process at the BRI, but we can't actually do it. So this only takes place at Southmead Hospital. So when a patient comes in, they'll have the CT scan, which we've already said, but they'll have an extra scan, which is where we inject a dye into the arteries, and it actually lights up it shows the arteries in the brain on the scan, and it shows if there's any clots or blockages in the arterial system of the brain. And if there are, we can actually send those images. So the scans will be emailed to North Bristol, to Southmead, for the neuroradiology and the stroke consultants there to look at. And they will look at the patient's medical history, they will look at the scans, and then they will see whether they think they are able to do this procedure called for. If they are, we'll have an ambulance, so we'll call 999 and we'll get you transferred up to Southmead, and the procedure is carried out straight away. You're actually met at the emergency department by the stroke team. At the moment, the procedure is only offered from 8 o'clock to 8 o'clock, so 8 a.m. to 8 p.m. 7 days a week, but they are hoping to go 24 hours, hopefully in the near future. Can I have the next slide, please? So we've talked mainly about the types of stroke where there's a clot involved, but we did say that about 15% of people will have what we call a hemorrhagic stroke. So they've had a blood vessel burst for some reason. So again, they still require urgent assessment, urgent medical assessment. So they'll have a CT scan when they come in. The scans are again sent to Southmead to the neurosurgical department for advice, because sometimes patients do get transferred up there. Sometimes it's not appropriate. We will actually manage them on the BRI site. Things that we look out for is we'll be monitoring patients' blood pressure, and if it's high and it's appropriate, we will try to lower that blood pressure quite significantly within the next 24 hours. It may be also that the patients will be assessed for if there's any medications we can give to reverse bleeding. It's not always appropriate, it's not always done, but it is something that we do. If they're not going to be transferred to Southmead, they're remitted to the stroke unit. And again, it's basically we're monitoring that patient very carefully to make sure that they're improving, or if there are signs of deterioration, again, we would contact Southmead to see if they think that there's anything they can do. Okay. All right. Thank you very much. I'm going to hand you over to Laura now, who's going to talk about hospital care.
Hi there. Hi. Yeah, I'm Lauren. I'm one of the speech language therapists that work at the BRI. I've been working with stroke patients for over 20 years. Very passionate about delivering, really high quality, evidence-based care to our patients. So I'm going to talk you through what we do on the unit and tell you a little bit about the different professionals that I work with who form part of the multidisciplinary team. First, though, I'd like to start by showing you a video. So I think that's just coming up for you now. And we just have to switch screens a little bit just to bring the video online. It's just a nice summary of what Pauline's talked about. And it's from the NHS website, so it's very accessible for people if you want to revisit that site. It's got lots of good information.
Blood to part of the brain is cut off. A stroke is a medical emergency, and urgent treatment is essential. What causes a stroke? To function properly, brain cells need a constant supply of oxygen and nutrients, which they get from blood. When the blood supply to part of the brain is suddenly stopped, brain cells become damaged or die. This can lead to permanent brain damage or even death. Different areas in the brain control the function of different parts of the body, each receiving its blood supply from 4 main arteries in the neck and their smaller branches in the brain. The level of brain damage caused by a stroke varies greatly and depends on the blood vessel affected. A stroke may go unnoticed if only a small blood vessel is affected. But if a large blood vessel is blocked, it may lead to long-term disability or death. There are 2 types of stroke. Ischemic stroke is the most common type, most often caused by a blood clot, or a piece of fatty material blocking an artery, restricting its blood flow. Hemorrhagic stroke is when the walls of a blood vessel in the brain become weak and burst, causing bleeding and brain damage. Transient ischemic attack, TIA or mini stroke, is similar to a stroke, but the brain's blood supply is temporarily blocked, and the effects of the blockage get better within 24 hours. The clot either breaks up quickly, or the affected area receives blood from nearby blood vessels. TIAs do not cause permanent brain damage, but are important because they are often a warning sign for a stroke. Other risk factors for stroke include increasing age, smoking, drinking alcohol to excess, obesity, diabetes, and high blood pressure. A healthy diet, stopping smoking, moderate alcohol intake, and regular exercise can all help to reduce the risk of getting a stroke. It is important to seek immediate medical attention if you have a stroke. The sooner you get help, the better the chance of a good recovery.
Okay, thank you. So, yeah, stroke's a pretty big deal, and it's important to get help early, as Pauline's saying. So if I can have my next slide just as soon as you've switched up, that'd be great. So just a few figures. There's 100,000 new strokes every year in the UK, and not forgetting that includes figures for children as well. 1.2 million stroke survivors, and 2/3 leaving hospital with a disability. So the Public Health for England estimates annual costs of 26 billion. And obviously that's a huge driver for a national focus on how we can prevent stroke. So hence today, raising stroke awareness. Next slide. So just to kind of summarize, I mean, the video touched on it, just the brain is so complex and unique. No one stroke affects individuals in the same way. So there are some commonalities like limb and facial weakness, but everyone's experience will be different, which is why we deliver, it's just so important that we deliver patient-centered care, and that's really central to what we do on the unit. So next slide. So it's important, obviously, to early admission to the unit. The National Clinical Guidelines for Stroke determine the what and how of what should be delivered, from acute care to long-term rehab through to stroke prevention. Therefore, early admission to the stroke unit is recommended for specialist assessment and care. Here, patients will meet a range of specialist professionals involved in providing those critical assessments and care. So next slide. So this isn't an exhaustive list by any means, but these are the most common people that you may meet on the unit, and I'll take you through each one, and I'll expand a little bit more on the speech and language therapist role if we have time along the way. So next slide. Sorry, next slide. I'm not sure if it's stuck.
Just bear with me a second.
That's okay. So the next one is focusing on the medical team and what their role is. Obviously, that they're critical in the early assessment and treatment in terms of thrombolysis and thrombectomy. Yeah, so that forms the sort of emergency acute medical care side of things, and the overall management decision making to progress treatment. And obviously, they have a large role in stroke prevention and research. So that's a photo of one of our consultants, Claire Holmes. Next slide. Obviously, the nursing care is paramount. It's 24 hours. They're there to monitor and observe, provide all the assistance and care that patients need with personal care, eating and drinking, making sure their skin's intact, looking after mouth care, dental care, all those sorts of things, thinking about their positioning and bladder and bowels. So they're obviously integral. So speech and language therapy. 1 in 3 stroke survivors can be affected by aphasia. So that's language impairment. So difficulties understanding or expressing words. There are more than 350,000 people living with aphasia in the UK today. Many of our patients also have dysarthria due to muscular weakness, which is sometimes referred to as slurred speech. although it can also affect your voice, resonance, pitch, as well as the articulation side of things. There may also be difficulties with the motor program for speech, also known as dyspraxia. So our role as speech language therapist in the acute setting is to provide that assessment diagnosis, look at treatment planning, goal setting, advice to the multidisciplinary team on the ward on best ways to communicate with people, what listeners and conversation partners need to be doing to make that easier for people. And then obviously broad education as well. Working with families, we also get involved with looking at capacity, so somebody's understanding of their situation and their decision making, that they we hope that they can engage with that process through the help of a speech and language therapist, perhaps looking at total communication, so that's incorporating lots of props and aids to assist with their understanding and help them to express themselves. So next slide. We're going to come back to the videos just together, so we're not switching out the screens. So that's a video of somebody with aphasia, just to give you an idea. We also have a role in managing swallowing difficulties after stroke. So on average, about 50% of people will have some kind of swallowing problem post-stroke. The evidence hugely ranges from sort of 40% up through to 80%, depending on how you define swallowing difficulties. But essentially, we provide training to the clinical nurse specialists to carry out swallow screening, and we're looking to broaden that out onto the medical admissions unit and directly into the emergency department as well, so people can meet that window of having a swallow screen within 4 hours. If patients are identified at risk, they're referred to us for more detailed assessment, and this may also involve instrumental assessment, which I can go on and show you through the videos. So we might start with a bedside assessment, and then we'll opt to look at instrumental. So should we go to the video fluoroscopy video first? It's just a short one. Just give you an idea of what the images look like. Okay, this is the communication one.
Scott. Oh, no. Sarah Scott.
That's right. And how old are you?
I can't.
Try.
I can't.
You're 19. 19.
Yeah.
Yeah. And what happened to you?
Stroke. School and English class.
Okay.
And I book and I read it aloud. But I can't because stroke.
And what happened after the stroke with your speech?
But I can't.
What do you do now? Every day?
Oh, speech, then the speech.
Therapy?
Yeah.
Okay.
And also riding.
Riding what?
Oh. Horses.
Yeah, good. And how do you feel?
I'm fine.
You're fine. That's good.
Okay, great. So that's yeah, this is the video just on the X-ray, the video fluoroscopy that we might do. So it just shows you a normal swallow and then the abnormal swallow. So what that enables us to see is exactly what's going on, and it helps to assess more the physiology of the swallow, and that can really have a good impact on any therapy that we might suggest, or changes in textures and positioning to assist with oral intake and ensure that it's safe. Sometimes, obviously, you know, if it's quite severe, it might be that people require nasogastric feeding until we can encourage the swallow. So this is another form of instrumental assessment that we have as well. So this is called FEES, which is Fibre Optic Endoscopic Evaluation for Swallowing. It's quite a mouthful. Essentially, it's a camera that goes up through one of the nostrils and shines a light down on the larynx. So you're looking, the second picture is looking down through the airway into the larynx. You can see the white kind of V shape are your vocal cords. And then at the very front of the diagram, I don't know whether I've got a pointer here, this is the esophagus, the epiglottis, and your esophagus is at the back, which is obviously closed at the moment. So when we're taking images, it's a live image via the camera that we record onto a unit, and we can obviously save the images and analyze them later. Next slide. So thinking about the other professionals that you might meet, there's the occupational therapists. They're looking at your activities of daily living. And this is a photo of someone, you know, looking at making some food and drink in the kitchen. So it might be something like that. It might be, you know, any kind of activity that they're used to performing on a daily basis. That's just one example. They'll also look at cognition, and there's some standards around being screened for cognitive problems. Sometimes they can be quite subtle. So what I'm talking about is just thinking. It might be that things take a little bit longer to think through, and decision making, problem solving, sequencing tasks, that sort of thing. They'll also look at your upper limb, any equipment needs that you may have, and visual assessments that may be appropriate. So next slide. And they're not forgetting the physiotherapist. Obviously they're looking at all the weakness and the tone in the muscles. They're looking at any mobility as well as stability of muscles. So they're looking at maybe how your body is, your trunk, and you know, it might be looking at whether you can sit on the edge of the bed in the very early stages, and progressing through kind of getting out of bed, beginning to take those first steps perhaps. So they work very closely with OT, and also they have a role in looking after patients' chests. If they're having difficulties with swallowing secretions, they may be involved in applying chest physio. So next slide. The dietitians, we work very closely with the dietitians, particularly if people are having swallowing difficulties. So they have a nutrition screening tool. So every patient that comes in will be assessed for their nutrition. They'll also help to manage the nasogastric feeding tubes with nursing staff and set up regimes, so people are well looked after, getting all the nourishment and fluid that they need. If they're managing some oral intake but it's not quite enough, they'll look at supplying supplements and any dietary advice kind of through to kind of stroke prevention advice. So next slide. We're very fortunate to have a psychologist on our unit. So she's there a couple of days a week. She provides a lot of training to the multidisciplinary team to support us. And also, you know, she's responsible for kind of overseeing all the mood screening. And she does provide direct interventions with patients and families in terms of, you know, coming to terms with what's happened and their adjustment and coping strategies. And she's got good links with tertiary services as well. Next slide. Obviously, you know, as I said, it wasn't an exhaustive list, and this is just a few other members of the team as well, not forgetting, you know, everybody's working extremely hard to pull together So, you know, all the radiographers that are providing all the screening and x-rays, the porters, taking people around the hospital, housekeeping on the ward, teams involved in planning discharge and the social workers, etc., etc. So, yeah. So having undergone a range of specialist assessments, as part of, you know, the multidisciplinary team work together with the patients and their families to set the goals. So there's targets that happens within 5 days. Obviously, if somebody's acutely unwell in the beginning, that might, you know, be further along the line. But we certainly work together to set targets to help progress function and recovery. Obviously, safety is paramount, and therapy will continue to be delivered on the unit with all the appropriate equipment and monitoring facilities to hand. But there will come a point when it's time to consider continuing rehab in another environment. So I'm going to hand over to Helen, who will talk you through how we manage the discharge process. Thank you.
Thank you, Lauren. Yes, hello everyone. As Lauren says, my name's Helen Ellis. I'm an occupational therapist. I'm also one of the team leads for the early supported discharge team for stroke. And as Lauren says, early on in the person's acute hospital admission, sorry, I'll just go back a slide, sorry. When the person's medically stable, discussion will take place as to when and where the person can continue their recovery in a community setting. Some people will require further inpatient care in a specialist subacute rehabilitation unit and then will transfer to the community from there. So examples in our area is the stroke unit at South Bristol Community Hospital. Some people will make a full recovery and not require any further rehabilitation, but they'll still undergo further investigations as an outpatient to try and find out the cause of their stroke and to try and prevent another happening. And either their GP or the stroke consultant will follow this up with them. And others will transfer straight from the acute hospital back home. And for those people still needing rehabilitation, the option of returning home with support from an early supported discharge team will be considered. So if we go to the next slide. So the National Institute for Health and Care Excellence recommends, as a result of evidence-based advice, that all adults who have had a stroke are offered early supported discharge if the core multidisciplinary team assess that it is suitable for them. And this enables people to continue their rehabilitation at home with the same intensity and expertise that they would receive in hospital. The decision to offer early supported discharge is made after discussion with the person and their family or carer, if applicable. And it takes into account the person's abilities, their cognitive, that's their thinking, skills, and their social circumstances. Examples that they may consider are the person's ability to move safely from bed to chair or with assistance, and whether a safe and secure environment can be provided at home. It's not suitable for everyone. And the main aim is it enables the people to continue their rehabilitation at home with the same intensity and expertise that they had in hospital. So if we go on to the next slide, this is a picture of the team that I work in. We happen to be based in the south of the city, and we've got one of our electric bikes there because we endeavour to go and visit people as environmentally friendly as we can. So we have electric bikes and obviously there's also vehicles to get to visit people in their homes. And as Lauren described the team on the ward, the team in the early supported discharge team is very similar. It consists of physiotherapists, occupational therapists, speech and language therapy, dietitian, nurse and therapy technicians. And the team work closely with the ward staff prior to the person leaving hospital. And in some cases, we meet the person and their family on the ward before they go home in order to help the transition from hospital to home. If any help is needed in, for example, getting washed, dressed, preparing meals or taking medication, then a separate referral will be done for additional care support in conjunction with the therapy team. And the team will visit the person either on the day of discharge or the following day to ensure a smooth transition of care and that they have the assistive equipment, such as a second banister rail on the stairs or a rail by the toilet, to enable them to manage at home. So if we go to the next slide, thank you. So what does the team do? So the treatment is focused on promoting neuroplasticity, or in other words, reforming and strengthening of neural pathways in the brain. And that's with the aim of teaching exercises to regain the skills needed to meet the person's goals. It's recognised that the transition from hospital can be a great opportunity, but it can also be challenging. The team is there to support the person to carry on the therapy started in hospital. And I'll talk a little bit more about what that might involve in the home setting in a moment. We support the person to re-establish their life at home, and we support them to find ways to take control of their recovery. And that all the input is focused on goals that are meaningful and relevant to their recovery. For example, preparing a meal, sending a text message to a friend, and taking the dog out for a walk. Types of intervention, so I'll just go back, sorry. The types of interventions initially is around strengthening those neural pathways, so the areas of the brain that have been damaged, that have been deprived of nutrients and oxygen. We look at strengthening pathways that may be damaged, or actually looking at alternative pathways that used to assist, to help out, to strengthen those neural connections to enable a regain of function. So that will continue the exercises that the physiotherapist on the ward have done, including working on balance and walking. And in the home environment, being able to walk the distance from your bed to your own toilet is meaningful, it's very appropriate, and it tends to work best in that familiar environment. We give exercises to strengthen and increase the movement in the affected arm or hand, if that is how the stroke has affected the person. And again, applying that to everyday activities. We teach strategies to overcome and improve difficulties associated with changes in vision and thinking. Some people, as Pauline mentioned early on, have loss of vision in one side, and we practice negotiating the outside environment, crossing roads, scanning to see and find things. We continue the work that Lauren's talked around speech therapy. People may go home with a slightly altered diet, a textured diet, if they're still having some difficulty swallowing standard fluids and diet. They may go home on a thickened fluid, and our speech therapists will continue to monitor that swallow. They'll also work with the person to help with their aphasia. And as I said earlier, it could be goals around texting, writing, speaking to people on the phone. During the pandemic, it's been around being able to have Skype calls with people, maintaining that important contact with family. And also exercises to work on any facial weakness. Our nurse continues to work with the person to look at ways of trying to prevent another stroke happening again. We give regular blood pressure checks, and we look at ways of maximising health and recovery. And we also monitor and support with mood and the psychological adjustment to having a stroke. And where applicable, we give advice around return to driving, finances, and return to work. Can I have the next slide, please? In some cases, it may not be possible to actually regain the ability or the skill as the person had prior to the stroke. And then we look at alternative ways of carrying out the task, which may be through the use of assistive equipment or adapting the environment. So here on this slide, you'll see there is on the right-hand side where the bath is, that's a bath board. And if you can imagine a shower over the top there, if somebody's having difficulty balancing on one leg to get in and out of the bath to use the overbath shower, it may be that their board can be fitted, they sit on the board and swing their legs over, and they can either stay sat while they shower or they may stand up from there, perhaps with the use of a rail. If weakness persists in the hand, then we can look at adapted cutlery, larger cutlery handles to make it easier to grip. There's some examples of some rails that can be put round the toilet. And also many people may start off with needing some assistive equipment to help them walk, such as a Zimmer frame or a stick. And on the bottom right hand corner there, you can see some adaptive equipment that can help if somebody doesn't have return of movement in their arm, or they're still working on that. But in order to maintain independence, there's an example of where you can peel a potato one-handed, or grate a carrot one-handed. Okay, thank you. So the team see approximately 40% of people who have had a stroke admitted to UHBW, and at the moment that's the the team I work with, it's the Bristol area only. The national target is 45%. At the moment our team doesn't cover North Somerset. North Somerset have a separate service for people leaving hospital, and I think we've got some representatives from North Somerset who may be able to answer questions on that if there are any. And we also have an equivalent team in the north of the city that cover the South Gloucestershire area. The vision for the future is to try and streamline services so that after hospital care is more consistent across Bristol, North Somerset and South Gloucestershire, and there's a big piece of work going ahead to try and make equity of service across our area. As I said earlier, we aim to visit people on the day of discharge or the day after, and we aim to hand over to community or outpatient services as soon as the person no longer needs the intensity of input that they would otherwise have had in hospital. And this could be, for example, physiotherapy outpatients, it could be on to community teams, and we also refer to other voluntary services such as the Carers Support Centre and Bristol After Stroke. So it's very much working together with other services to get the best possible outcome for the individual. So on that note, I'm now going to pass you over to Rebecca Sheeny and Verity Aldous, who are going to talk around some of the after-stroke care from Bristol After Stroke and the Stroke Association. Thank you very much.
Thank you, Helen, and a lovely segue to our services there from you guys. My name's Rebecca Sheehy and I'm Chief Executive of Bristol After Stroke. Bristol After Stroke's mission is to support people to adapt to the massive life change that stroke can be. Stroke occurs suddenly, as we've discussed earlier, and overnight a life can be turned upside down. Someone could be leading an active life, working, running a family, having many interests, and then the next day be very disabled, learning to walk again, learning to talk, having difficulty processing things, dealing with fatigue and issues like that. And Bristol After Stroke is then there to support the stroke affected people and their families rebuild their lives and help them navigate services and support that will help them forge forwards. Bristol After Stroke's an independent local charity that's been operating in the area for 38 years. In response to our mission, we've set up a few services that support the diverse needs of people with stroke. And this presentation's just going to give you a quick overview of the support we provide in Bristol and South Gloucestershire. And then Verity is going to talk about what happens in North Somerset. Thank you. So, set the scene. I've here a little pathway description of our services. And you might meet our stroke coordinator here in InReach, and that means that they'll be in hospital. Sometimes we go into places like South Bristol Community Hospital or Southmead, and we meet people and we give advice and support at the bedside. And in Southmead, under normal circumstances, we would do a monthly cafe there as well for people that are on the ward at the time. From there, from doing our work in the InReach, you might be referred to us, but anyone can refer to us. So family members or health professionals can refer. And then you would go to get a stroke coordinator assessment. So the stroke coordinator would contact you and then they do a visit and talk through your needs. In South Gloucestershire, we also undertake a 6-month review. However, but we don't currently do it in Bristol. However, we're working with the Stroke Association to aim to provide everyone in the region with a 6-month review in the near future. Next slide, please. Lovely. So our coordinator here summarises some of the work that they do with someone. They offer varied practical, emotional support, secondary prevention support and family support. People have such varied issues, and in 1 week a stroke coordinator may be supporting housing issues, referring to benefit advice, arranging interpreters, supporting people with health issues, referring to continence services, and importantly, referring on to places where people can meet other people in a similar situation to them, helping them feel that they're not alone in this situation and offering important emotional support. Go to the next slide. Lovely. Just to give you a taste, these are some of the quotes from the weekly updates I get from the stroke coordinators. So, liaised with Red Cross to sort shopping for a vulnerable and self-isolating lady who has a son with long-term mental health difficulties. There have been some misunderstandings which I managed to sort. Arranged for a new client to have a food parcel delivered from the food bank within 1 day. Contacted a client who is really struggling and made sure a counselling referral was already in place. I will continue to ring them. Supported a client who has been blocked by her employers from going back to work, discussed her rights under the Equality Act. Next slide, please. Thank you. And then we go on to other services that Bristol After Stroke provides. So we offer emotional support services and peer and rehab type opportunities. So we have Action After Stroke and counselling, and then we have stroke support groups, stroke cafes, an aphasia group, and our Next Steps physio group, which I'm just going to explain a little bit more about. So can we move on? Brilliant. So we offer counselling, that's one-to-one support to help people with the kind of massive adjustment that they may be experiencing, just trying to understand who they are now, because it's impacted so much on their view of their self and their identity. We also, the counselling is one-to-one, it's short-term and per person centred. We start with a 6-week offer, but we're able to extend if necessary. We also offer a psychoeducational course called ACT, and it's based on acceptance and commitment therapy, and helps people learn ways to manage stress and painful feelings. It teaches us that we can learn to accept the things we can't control and focus on changing the things that we can, very much like the Serenity prayer here, which says, well, I won't repeat it as I've just described. Grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. Next slide. Thank you. We've got 5 weekly groups. We're also doing a newsletter and a telephone group and a virtual group at the moment. When we go back, I'm expecting to have the same weekly stroke groups. We also have 2 stroke cafes, which are drop-ins in Bristol and North Somerset, in Bristol and South Gloucestershire. Next slide, thank you. And we're running a virtual aphasia group. This is just a slide, and it has a picture of some pictures that people have drawn of how it feels to have aphasia, which we did in the group that we run. It offers a place where people can gain confidence in their speech and practice their speech, very important things, and meet other people in a similar situation. Next slide. Next Steps is our physiotherapy course. It's in normal circumstances, it's 8 weeks long. We've just done a 10-week program online, but we're all going back to 8 weeks face-to-face, hopefully in September. It helps people with balance, strength and mobility, and the group element of it is really important. We run health educational topics alongside the physiotherapy, and it just helps people with their motivation, being in the same boat with other people and feeling invested in other people's successes. Next, thank you. It appears to be blank. All right, it's coming up. So this just run through it, because it's here I'm just talking about you can also volunteer. It's really important. Lots of people that have a stroke then go on to volunteer with us, which is a really nice way of giving back to others and supporting others. You can help our groups in cafes and in various places, and help us with fundraising and in all these ways that you can volunteer. So if you're interested, do let us know. And then finally, the next slide, how you can help. If you're interested, you can become a friend of Bristol After Stroke, and you can, through that friendship, we'll stay in touch with you. You can support us, volunteer, and help spread the word. Thank you. That's everything from me.
Thanks, Rebecca. I'll just give you a very whistle-stop tour of what we do in North Somerset. So I know we haven't got a huge amount of time. So my name's Verity Aldous, and I'm one of 2 coordinators that run the Stroke Recovery and Communication Support Service in North Somerset. Could go on to the next slide, please. So our referral criteria, so who we can support is anyone who's had a stroke or TIA living in North Somerset, aged 18 or over. And we also support family members and carers of stroke survivors. And also, it doesn't matter if your stroke isn't recent. Obviously, most of our referrals are recent strokes, but even if it's, you've had a stroke sort of 5 years ago, you can still be referred into the service. Next slide, please. So just a brief overview of what we can provide. So when we were, just quickly to say, we were doing a bit of in-reach work as well at Western General Hospital pre-COVID, drop-ins on the ward, and we have a monthly stroke cafe, which hopefully we'll be getting back to resuming when we can. So when we get your referral, we will contact you usually within about 3 days, just for that initial phone call, just to make sure that we've sort of introduced ourselves and you've got a named coordinator and contact number and email address, and we'll also give you the stroke helpline number, just so you've got that that immediate support. We'll then arrange to carry out either a home visit if that's appropriate at the moment, or we may arrange to do a video call or telephone call just to carry out an assessment of your needs, and look at sort of goals for the future. And it provides you just, a chance to talk over any concerns you've got, what to expect for the future. We can give a range of information about stroke and its effects, and then we'll either email or post out leaflets and fact sheets, which we've got in a range of languages. We've even got some audio information or large print that we can send out. And then we have our virtual support groups that we're running at the moment. And we can sort of provide limited support to try and get people connected to these. We have sort of got grants for people for laptops, and we can provide a home visit to sort of get the person set up and sort of teach them how to use the various virtual platforms to get on there. Similar to Bristol After Stroke, we work with a lot of other organisations, and we can sort of signpost and refer onto those, help with returning to work. We've got a separate communication support service, which is run by my colleague, Simon Lakin, and we're offering virtual communication groups at the moment. We also have carers support groups, and again, sort of in touch with local leisure and social activities. Next slide, please. So this is just an overview of groups that we had running prior to COVID, and that hopefully we will get back to in sort of the coming months. So we have 2 speakability groups, that's Weston-super-Mare and Clevedon. So they are for any sort of stroke survivors where their communication's been affected. So it's just that sort of safe, supportive environment in order to meet others in a similar situation and be able to practice their communication. We have 2 carer support groups, one in Weston and one in Aylesey. We had a golf group in Tickenham, which was doing really well. Hopefully we'll be able to get back to that one soon. Next slide, please. We had a lovely arts and crafts group, which is really being missed at the moment. A young strokes group in Weston, the stroke cafe at Weston Hospital, And then we also had a stroke survivors group in Nelsey. And then my colleague Simon runs the Communication Plus group, which it's like a block of 10 sessions. It's quite a small group environment, and that's sort of taking place at various locations around North Somerset. So there'll sort of be maybe a 10-week block in Nelsey, and then the next one would be in Weston, and just moves it around a bit to make it a bit more accessible for people to attend. Next slide, please. The other thing that we let people know about is our online tool called My Stroke Guide. So this is for any stroke survivors, family members, carers, stroke professionals. Anyone can sort of set up a login, and there's loads of great information there, videos about various different things to do with stroke, access to local support. There's goal setting on there. There's chat forums, loads of things. So it's a really great tool to point people in the direction of if they've got the technology. Next slide, please. And then of course we've got our helpline, which we always give people the number to. So that's open most days, and if they can't get hold of their local coordinator or just want to talk to someone a bit more anonymously, then they can always phone the helpline. Next slide, please. And of course the website as well. It's a great source of information. They can find out about local services and connect with others. Next slide, please. Again, our social media pages. So if anyone wants to keep up to date with what's happening locally, if you follow our Stroke Association Southwest page, there should be local updates on there. Next slide, please. And then finally, our contact details. So I realise it's been quite a whistle-stop tour, but say if anyone does want any, anything in more depth, any more information, then please do get in touch, and we can give you that. Thank you very much.
Thank you, Verity, and thank you to all our speakers. That's been incredible. Just the sheer amount of support from beginning to end.